Let me know when you're ready, Sangeeta.
Yeah, it's started.
Hi, good evening. Today is 8th of December 2021, and this event is being organized by The Mentoring, a charity that supports vulnerable people through mentoring in the areas of education, employment, health, and community cohesion. Welcome again, and thank you for joining in today, all of you. It's lovely to see all of you here. Those who do not know, this is our third of the series on COVID information. The purpose of today's session is to provide some education regarding how to recognize misinformation online, working through several examples relevant to COVID that have been in the media in the past. Dr. Milind Girish, doctor working in London, who just recently qualified with a distinction from Cambridge. Milind is currently working on a COVID ward. We also have a Q&A session, that's question and answer session later with Dr. Rajiv Madula, consultant respiratory physician, King's College Hospital, London. Rajiv works at the front line of managing patients with severe COVID-19. We are proud to have you both here this evening, Rajiv and Milind. Please put on the chat or any questions that you have, and you can say hello to each other, and your comments will be very helpful for us. We want you to be on mute, please, so that we don't disturb the speakers. You can choose your camera on or off, depending on whether you would like to be in the recordings. The event is being recorded, just to let you know, and so if you prefer not to be on the video, please turn off your camera now. To ask questions, tap the chat option along the bottom of the Zoom panel. We may not be watching straight away, but we would definitely get back to all your queries and then put them back to the panel members. If at any time your connection drops, you can re-access using your original Zoom link that you have been provided, but alternatively, you can use password and meeting ID that we shared with you earlier. Without wasting much time, I would like to hand over to Dr. Milind Girish. Over to you, Milind.
Okay, let me just share my screen. Okay, I should be sharing my slides at the moment. I'll just speak quickly 5 to 10 minutes regarding, firstly, answering a question that we received last time that I sort of spent some time looking into and therefore have an answer for. And then second is a brief little explanation of something regarding vaccines, which might be interesting to hear. It'll be about 5 to 10 minutes, and then we'll return to the Q&A to answer questions that anyone has. And as that's already been linked, the previous talk is in the bottom right of this slide. If anyone wants the slides, feel free to request them, and we can send them on as well. So the question that we had last time stemmed from a document from the government that was sent on the chat, and it's a vaccine surveillance report that's repeatedly released by the government quite frequently. And it's this specific report that, again, I've included the link to at the bottom of the slide. If anyone wants to look into the document themselves to see what I'm sort of saying and where I've got it from, it's from there itself. Now, the question was that someone presented this document, and then that they said that they'd heard that this document stated this. They'd heard that this document said that multiple vaccines reduced effectiveness of the immune system to COVID. Now, clearly, this is quite a worrying sentence, quite an alarming thing to hear, actually, especially if it's in a government document. But the person who'd raised this question hadn't read through the document themselves. And to be fair, this document is quite long. So obviously, at the time, I hadn't seen the document before. It's a very long document. I didn't have time to go through and answer at the time. So subsequently, I've looked through, and I think I found the exact piece, the exact excerpt from which they've got this conclusion from. And it's actually quite a good example of how sentences interpreting data can be misinterpreted, and how it's good to bring these up with others and ask for what they're interpreting, perhaps the research is saying. So what I've highlighted here, we can see, is that this is directly from the document as well. The document states reduced antibody response and vaccine effectiveness were seen after one dose of vaccine. And that's where they got this conclusion from. They read this and thought that vaccines are reducing the effectiveness of our bodies against COVID, and that's very scary to think. However, I think what's been misinterpreted here is this part, among the immunosuppressed group. So what's the actual interpretation here based on the research that's linked in this underlined bracket here? The actual interpretation is that patients who are already immunosuppressed show a reduced immune response to the vaccine versus quote unquote normal patients who aren't immunosuppressed. And this is completely expected. If your immune system's already reduced, your response to the vaccine is going to be reduced. And on a brighter note, they actually noted that when you give the second dose, this reduction in efficacy is smaller. So this claim is not correct. The alarming claim is not something to worry about, and this is the actual interpretation. And again, the links are below. Now, I'm just going to quickly finish with a little brief explanation on something that you might want to request if you went to get the vaccine yourself. The vaccine is an intramuscular injection. And what that means is that we go straight in, typically at the shoulder, and we want the vaccine to be injected into the muscle, and then it will form a little bit of a pool here, and then the body will react to it and form an immune response, and that's how we're protected. What we don't want is the needle ending up inside a vessel, and then perhaps the vaccine might be spread systemically. It might spread across through the blood. Now, this is actually why we use the shoulder, because the shoulder where we inject the most vaccines is an area that doesn't have a lot of vasculature, and it doesn't have very large vasculature. So the chances of this happening are extremely small. And you can see that just from this diagram. The chances of the tip of the needle specifically stopping at this vessel here seems quite unlikely and small. And again, this area itself has less vasculature and a lower size of vasculature. So how do we know then that this needle hasn't stopped there inside this vessel and that we're not injecting into a vein? Well, there's something we can do called aspiration. Now, what that means is that once you go in with the needle, before injecting the vaccine, so before pressing down on the plunger, you actually pull back on the plunger, like you can see this person here doing. So in this situation, they haven't yet injected the vaccine's still in the tube, but they're pulling back. And what should happen is that no blood should show up, because what should happen is that needle tip should be in the muscle, you're pulling back, and you might just see air there. You should not see any muscle. If, in the very, very unlikely chance that that needle tip is in a vessel and you pull back, then you would see blood come back into the needle. And that's how you know that you're in the wrong place and you shouldn't inject the vaccine into that place. And in that situation, you usually pull out the needle, perhaps replace the needle, and then just go at a different site in the deltoid, the shoulder. Now, interestingly, there are various countries, for example, Taiwan and South Africa, the ones that I know of, where this aspiration is mandatory. And that's mandatory for all of their vaccination programs. Interestingly, the UK and actually the US as well, the UK and the US both don't mandate this. So there are a lot of vaccinations that are going on where aspiration is not being done. And now the idea behind that is that it's genuinely a very, very, very small risk. Like we said, the chance of it stopping right here and the area itself not having many vessels, the chance of this happening is very, very low, of the vaccine going into your blood. But the trouble is, a low chance doesn't necessarily mean zero chance. And aspiration, what I've just described, this explanation here, is something that doesn't have any sort of side effects if done correctly. There's no cost to it. It's very easy to do. Most healthcare professionals know how to do it. And so honestly, it's very easy to just recommend, if you were to go get a jab, just ask whoever's giving you the jab to just aspirate before they inject the vaccine. And it's very, very easy to explain what that is. They should know already, but if not, this sentence here should sum it up quite well. And that's basically the summary right there. But aspiration isn't really mandated in UK at the moment. So if I was to go get a jab at the moment, I would ask them to aspirate before giving the vaccine. That's basically the summary right there. Thank you for listening.
Thank you, Milind. Do you have any questions? Whoever is online, shall we move on to Q&A? Rajiv, you want to say something about
And so, no, I think Milind makes a fair point about the aspiration. It's something that we're actually taught even back when I was a medical student as part of what we call OSCEs or exams, that you should aspirate before you give an injection. So even I've learned something new in knowing that it's not something that's been mandated from us, but I think it's very easy and simple just to request whoever's administering the vaccination just to do the aspiration before administering the vaccine. It's a very simple and easy thing to do, and it's something that we were taught, and I feel actually should be done as well.
One of the reasons why some people had rashes or something, because of that, because they haven't done as.
I wouldn't think that probably a rash is because they haven't done an aspiration. You know, if you pierced a vessel, then you could get something small like a hematoma, but that's more of a bruise rather than anything else. But really, if you're talking about a rash, that tends to mean, for me anyway, that it was some sort of allergic reaction to to possibly something associated with the vaccine. Although if it's local, it could be a lot of things. But the thing that you'll be asked about when you get the vaccine is whether you've got a history of anaphylaxis, which is essentially severe reaction to anything, really, any kind of medication, because that can be a life-threatening emergency. But I think most people will know if they've ever had anaphylaxis. It's not the same as just saying that I'm allergic to something, like saying you've got hay fever, for example. Anaphylaxis is something very different.
I think somebody wanted to ask some question. They want to be anonymous. You would like to put it up in the chat, or you want to say something? Hello.
Yes, I do want to ask a question. Two, actually, in fact, for the price of one. If not aspirated, which very often happens, injected into a vein, vaccine injected into a vein, does it cause severe side effects?
Perhaps I can have a stab at answering this. The trouble with this is that the research doesn't really exist for the answer to that question. We can't like get humans and then inject the vaccine into a vein and then see what happens, because that's completely, like, clearly that's like unethical. Research on mice does show that you can have side effects if you inject it into a vein, but that's not, in that situation, that research is not showing accidental injection into a vein. It's showing direct injection intentionally into a vein to see what happens. So again, are we saying that there are people out there who are definitely having side effects because we're not aspirating? We don't know the answer to that. What my point was that to mitigate the risk, to completely reduce it to zero, if you ask for aspiration, then that's what you can achieve.
Right. So if I were to go for my booster and ask to aspirate it, check, make sure the needle is into the muscle and not into a vein, what if the person doing it refuses to do so?
That would be unfortunate, because it's your body, honestly. You should be able to decide how someone injects a vaccine into it, and it's not a intervention that's, you know, dangerous at all. And it is taught. I too was taught when I learned how to do intramuscular injections that you should aspirate. But interestingly, when I was taught in a way that it was like, you should aspirate, but you know, we never get flashbacks, so it's not really, you know, it's not really worth aspirating. But you should do it if you know you should do it, is what I was taught. And obviously, like, it's very easy to do, so I would do it when I give aspiration.
So basically, what you are saying, that's the correct way of doing it.
Yes. Yeah.
Thank you.
So everyone should know what aspiration is, and if not, it's very easy to explain, and it doesn't. And it's easy to explain that it doesn't have consequences. So hopefully they shouldn't react like that.
Right. Okay. Thank you. My next question, if you don't mind, either of you, Dr. Raj Madula or Dr. Girish, if a person suffered severe headaches, heart pumping, heartburn, etc., over a period of several days, over a week, with the first jab of AZ, The second one was okay for a couple of days and recovered well. Is it safe to be injected with a different vaccination, i.e. Pfizer? The patient has various underlying health conditions and also allergic to some medication as well as food.
Rajiv, you would like to take that question, please?
Yeah, I mean, I'll try and break down the question. So you talked about the patient having various comorbidities and also allergies as well. I mean, so, you know, whenever they get vaccinated, they will ask specifically about those allergies. But as I mentioned, it would be more if there's a history of anaphylaxis, which is a severe allergic reaction to any form of medication. If the patient's had that before, then they may need to look through which particular brand of vaccine they're having and see if there's any link between the two, for example. With regards to your as you're saying with AstraZeneca vaccines, my understanding from the question that the patient had symptoms quite severe from the first dose, perhaps they slightly attenuated from the second dose. And now the question is about the Pfizer vaccine and side effect profile. So that, I admit to you, is a slightly tricky question to answer. We can't always predict how each individual will react to a vaccine, for example. So when we talk about side effects from any kind of medication, so we have what's called the MHRA, which is the Medicine and Health Regulatory Authority, and when they essentially they're essentially the ones that are responsible for monitoring, for example, the side effects of various medications. We've got something called the British National Formulary here as well that we use. So when they talk about side effects, they rank them into things. For example, if side effects are very common, that means 1 in 10 people could, in up to 1 in 10 people could have a side effect. When we're saying something is common, we're saying anywhere between 1 to 10 to 1 in 100. When we're saying rare, it's 1 in 100 to 1 in 1,000. If we're saying something's very rare, we're talking about 1 in 10,000. So, you know, we know with COVID vaccines that certain reactions, like you talk about headaches, could be labeled in the common category. So yes, you could say up to 1 in 10 people could suffer from that. So I would have to say that, you know, if you're taking a Pfizer vaccine, the side effect profile would perhaps be the same as with taking the Pfizer vaccine individually. In answer response to your, perhaps the specific part of your question where you're asking about, because the 2 previous were AstraZeneca, would that increase the risk of you having a Pfizer or vice versa? I'm not sure that's a question that I can specifically answer, to be honest, just that particular part of the question. But we know vaccines in general have a good side effect profile. As we've said, what we would interpret as common, things like headaches, perhaps up to 1 in 10 people. So I think your friend may have been, or your friend or the patient you described may have been in a slightly more unfortunate category of patients that may have had more lasting and more significant side effects, but that's certainly not the rule. So I'm not sure if the Pfizer vaccine specifically will cause any worse side effects than having had the AstraZeneca one. I think you just have to treat it as an individual vaccine. So whatever side effect profiles associated with the Pfizer vaccine, your friend would perhaps be at the same risk. But as I said, common ones, or what we're saying, common ones like headaches and things, it are actually relatively uncommon when we're saying something is 1 in 10.
Right. Okay. Thank you.
Rajiv, we just recently saw on Twitter that Pfizer, those who've had booster dose, Pfizer is more resilient to Omicron. How far it's true, and both of you could talk about misinformation or information, or about the right information from you, Rajiv.
I mean, obviously Pfizer have released the data, so I'm not sure it's a question of perhaps maybe misinformation in this instance. It's perhaps how the information is being interpreted, which, you know, Melinda, I'm sure we'll talk about. So if you're talking about what Pfizer have released, obviously it's only very recent, so even I'm getting to grips with what was released. But you know, we have to boil down your immune system. So our immune system has an innate response, which is how we all respond to any kind of infection that we encounter. So this is a release of various inflammatory what we call cytokines in the body, together with your white cell response as well. But then boiling this down further, we've got what we've said is your antibody response, which is what most people will have heard of throughout this pandemic, and vaccines and antibodies, because that's, you know, that's how they function. But what gets forgotten about is kind of your memory cells, or your memory responsive immunity, which is called your T cells. Okay, and they're the ones that tend to essentially go and affect infected cells and prevent and essentially apoptize them or kill them off, essentially, not in a bad way. This is all part of your immune system working in a normal, healthy way. And my understanding of what Pfizer, some of the research Pfizer specifically have done with regards to the Omicron variant, they were looking at what's called neutralizing antibodies. They found that people that had 2 shots of Pfizer previously had even up to 40 times less of volume of these serum antibodies. That doesn't necessarily mean that you're 40 times at risk of catching COVID. And I think that's where people start getting a little bit worried. So I think they showed that people that had previously had 2 vaccines had fewer of these neutralizing antibodies to the Omicron variant. But then when you had an extra booster dose, it sounds like from what they've released that your neutralizing antibody levels do return to that equivalent of somebody that's had, you know, that was from the first wave having 2 doses, for example. There's some other data, I think, suggesting that hybrid immunity, so that's vaccination together with people that have had COVID as well, offers actually, in fact, extra protection potentially against Omicron, if we're basing it on these antibody levels. So I think this is maybe where Milind can jump into what they're actually talking about in terms of antibody levels and what that actually really means in terms of getting infected from the virus itself, and perhaps mortality and hospitalization. I think, is that fair, Milind, maybe?
Yeah, antibody level is quite difficult for, you know, when we interpret, like you said, like the 40 times difference in an antibody level in the blood doesn't necessarily correlate to 40 times more infection or less infection. Often, therefore, it's easier to look at things like hospitalization and like symptomatic COVID and mortality, which is like who's dying from the vaccines. And I think it's very early. It's only been a few weeks since we've like really like started getting data, and obviously with such few people, let's hope there's such few people infected with Omicron so far that we don't have the data on that, because you need more people in research studies to know the answers to these questions. And so we don't have figures for like mortality. I don't know if we necessarily even know if Omicron is more or less transmissible at this point. Like, is it easier to catch? We don't know if it's more or less deadly, if it's more, you know, it might be less, it might be more. This is probably things that will come out over the next few weeks and months as hopefully not as accelerated, but more people will get Omicron. I think that's an inevitability. And then we'll have more answers to these questions. But it is difficult to know what to look at. I think things like antibody levels are very easy to get markers on this early in a pandemic, because you can isolate an individual who has the Omicron variant and then take all these values from that individual. But the sort of larger scale values that really matter with hospitalization and mortality, we don't really have the answers to those questions just yet. So it's too early to make these conclusions, I think.
Thank you both. Yeah, go on, Raju.
It's worth saying, because of obviously there's a lot of fear about Omicron, and that's understandable, it's natural. It's a new variant. So with Delta, so if we talk about mutations, Delta had, you know, in particular in the certain part of where Delta is, where the antibodies act on the Delta variant, there were about 9 mutations, what we call the spike protein part. Omicron has, I think, about 32. So it has a lot, and that sounds scary. But as we've said, what does that actually mean in context, in terms of obviously the antibodies that we have are still likely to be effective? It doesn't necessarily mean that you're going to end up with severe COVID as well, just because something has 32 mutations. So we don't have a lot of this information yet, because Omicron has been around for so low. There's some fear about transmission of Omicron. Well, again, we don't have that data as well. There's a lot of stuff that was done in Southern Africa, because that seems to, for example, seems to be where more of an outbreak is taking place, although we know that Omicron is all around the world, not just localized to South Africa. but there's a lot of, the important thing I want to say perhaps from this message is that there's a lot of confounding factors when we talk about COVID and transmission, for example. So I'm talking about South Africa, for example, where they have approximately 20 to 30% vaccination rate. They have a much younger population as well. So, you're talking about how Omicron is affecting South Africa, where they have very, very different population demographics to the UK. So you can't compare what perhaps is happening in South Africa to what could potentially happen in the UK. And I'm not saying that to scare people. It's, as we're saying, from both angles. We're going from both angles. Is that you can't compare directly what's happening in South Africa to the UK, for example. So we don't have that data yet, and I'm sure it will emerge in the coming weeks and months. Because we have to take care of all those. When we look at the data, we have to analyze all those confounding factors of those people who are vaccinated. Did they have comorbidities? What age were they? We need to get all these parameters, and then only can we give an answer to say something is more transmissible, and what kind of factors predispose to the general public.
Is there anybody who'd like to ask any question, or can I ask? Well, I have a question. What are the symptoms if somebody has got Omicron? Is there any symptoms or anything?
So again, I mean, the thing is, again, we don't know too much about Omicron. We're just learning about it now as a variant. Again, a lot of this stuff, some of it is anecdotal, and we're saying, because you have to be careful about what you're hearing anecdotally. So we don't have a lot of information yet about what its virulence is. Is it leading people into getting more severe disease or into hospital? But it's still fundamentally a coronavirus. It is a SARS-CoV-2 virus. So you would expect that the symptoms are the same as any kind of viral flu-like illness. So, the headaches, the myalgia. But obviously, as doctors, we tend to be more concerned if it's affecting the lungs in terms of shortness of breath, cough, all of these sides of things. So it's still a COVID virus, coronavirus. So the symptoms will still be very much similar to other strains. But as we've said, it is a new variant. So knowing whether it puts you at other risk of other problems or mortality, again, that's all. We don't have those specific answers yet, but the symptoms we would be expecting you to look out for the same symptoms as with other variants of coronavirus that we've encountered to date in the last couple of years.
I just recently read a couple of days ago that whoever got Omicron, they sweat a lot, I believe, in the night. So even if the bed is cool, they sweat, I believe. So I don't know how far that's true. So that's the reason why I asked you, what are the symptoms? You both work in COVID wards. So did you get any patients or somebody who had these symptoms?
I mean, I think from what I understand so far in the hospital I work, I haven't specifically been told that any of the patients that we've seen with hospitalized COVID have got the Omicron variant so far. But so it's very difficult for me to tell you anecdotally whether they've said that they've had more sweats, for example. So sadly can't answer that question specifically just yet. But as we said, in the next coming weeks or months, you might be finding people reporting or responding with a higher number of specific symptoms related to the Omicron variant. But sadly, I don't think we're going to have that data probably for several months, in all honesty.
Do you mind if I ask a question? It's more of like, perhaps you could share your experience on this, because clearly you've been working in a COVID ward far longer than I have, and just starting work on a COVID ward, I've been struck, and I think that general population might find this interesting, at how many of the people who come in with severe COVID are just completely unvaccinated, and they have their own reasons for that. Some are worried about things that we discussed in the previous talk, like fertility. Some are worried because of reactions. Some are worried of directly becoming unwell after the vaccine. And so many of them are unvaccinated. It's genuinely very, very common. You just look at the COVID ward on a given day, and a huge proportion of them will be unvaccinated. I was wondering if that's a trend that you sort of noticed as well, whilst we're working in COVID wards, and what you thought about that as well.
So yeah, no, that's a good question, and yes, it's a trend that we're seeing as well. Again, anecdotally, although we do have some limited data so far, perhaps in the last month or two, to back that up as well. But yes, the patients that I've been seeing, perhaps in the last 3 months, when I'm on the COVID ward, the majority of them have been unvaccinated, and it's important to say, perhaps, distinction when myself or Milind or other doctors are talking about severe COVID, from our definition, or as a chest doctor definition, we're talking about the oxygen that they're requiring. So these are people that are requiring high levels of oxygen. They're not necessarily all ending up, sadly, being put into a coma and having a breathing tube or a ventilator, or all these things, but that is also severe COVID. But we're talking about people with severe COVID in high levels of oxygen, people that are very sick, essentially very sick with COVID. So from that perspective, the majority of patients that I've seen are unvaccinated in the last 2 to 3 months, or more, really, in fact, in terms of time period. If they have been double vaccinated and yet still end up in that precarious position, I've seen some patients where, sadly, they've been unfortunate in that they've presented perhaps only a week after their second vaccine, which is not enough time for the antibody response to develop. But I've seen a lot of patients that have varying comorbidities. Milind pointed towards one data sheet that was talking about immunosuppression. I've treated a couple of kind of severe COVID patients in the last couple of months who, for example, have transplants, for example, liver transplant, kidney transplant. And these patients are heavily immunosuppressed and have ongoing immunosuppression despite COVID being in the outside community, because otherwise their transplant won't survive. So they are a more risk population. We know that, and that's why they were identified earlier to have booster vaccinations, and they will probably have them sooner going forward as well. So yes, the people that I've seen are majority unvaccinated, or if they've got severe COVID, despite having double vaccination, it's usually because they've got some underlying significant comorbidities such as immunosuppression.
Thank you very much, Rajiv and Milind. Are there any questions for us to pose to Rajiv and Milind, please, from the floor? Or do you want to say anything, any message, Rajiv and Milind, to our audience on YouTube, maybe?
My message would remain the same. And so obviously this is a session on COVID and COVID vaccination predominantly. And my message, it would be really the same, that the NHS as an organization will still recommend COVID vaccination, that we feel, well, not just from feelings, but from evidence-based, that it does lead to less severe disease and hospitalization. Nobody is saying that having COVID vaccination will prevent you from having COVID, I'm afraid. What we're saying is that there's less of a chance of having severe COVID and leading to hospitalization, and perhaps some of the other significant comorbidities, other significant problems associated with that. So we'd still find it in your favor to have the COVID vaccination. There are some, what we would term, common side effects. You had one caller in talk about headaches, for example, but really it's the pros and the cons, it's the risk versus the benefits, and we feel that and evidence-based, we feel that the benefits outweigh the risks. And I suspect Milind will have a similar answer, but maybe talking more about the information side of things.
Yeah, absolutely. One of the things that people are often concerned about is the side effects to the vaccine. All these, the clots that we hear about, the heart problems, and looking at the evidence base, even with that, these are extremely, extremely rare. And these very same problems are actually seen within COVID itself. And if you look at data comparing, the incidence of these things in COVID compared to the vaccine, it's orders of magnitude far, far higher. The people getting clots because of COVID, the people getting clots because of COVID infection rather than vaccines, even things like fertility issues. There's some data suggesting that fertility, I think I discussed this in my last in the last talk, actually, that there is some data suggesting there's fertility issues from COVID, and that's actually much stronger evidence than any evidence saying that there's fertility issues with the vaccines. So again, it's a pros and cons, and the overall message is that vaccination is the best option.
I know we've been told that vaccination is the only defense for this, pandemic, COVID, but there's another question here, sorry. If a patient has been on high doses of steroids in the past, immunity damaged as a result of these vaccines cause any issues? Over to you both.
So if your question is about somebody having had prolonged courses of steroids, so they would be in what's called the immunosuppressed category because they've had high doses of long courses of steroids. So if you're in the immunosuppressed category, if anything, that would put you at a higher risk of, if you contracted COVID, then that would likely put you in a higher risk of having the severe form or being hospitalized with it. But the link between vaccination and prolonged courses of steroids, that there is no specific there's no specific interconnection between those two in terms of if you're talking about a side effect profile from a COVID vaccination. But that individual, they would most probably have been identified, because even I have to identify these patients in my practice, those that are termed immunocompromised, particularly those that have had long and prolonged courses of prednisolone, would be prioritized to have a booster vaccination. But it shouldn't be a link between the two in terms of the steroids affecting the effectiveness or the efficacy of the vaccination, for example.
Are you okay with the answer, Pam? That's what it says, Pam, here. If you have anything, you can put it up in the chat, or you can unmute yourself.
Yes,
and ask.
I'm satisfied with the answer. Yes.
Okay.
Thank you.
Hey, do you want to say something about long COVID as well, Rajiv? Because that's your area. What is it?
Oh, so so they actually suggest it's not that long COVID isn't specifically my area. So so long COVID, it's a very loose definition. It's still the old definition, which is really symptoms persisting from COVID, or even we're saying suspected COVID as well, 12 weeks post the initial illness episode, or first testing positive, if you want. But it's a very loose definition. It can include a whole range of symptoms: fatigue, lethargy, shortness of breath, cough. I mean, the list can go on, and it's a very long list. So long COVID is slightly different. When we're talking about long COVID, it's important to say that from a long COVID perspective, we're not saying that there have been any long-term damage done to the lungs from COVID with a long COVID. That's not what we're saying. That's a completely different thing. These are perhaps people still having symptoms that may be related to the original COVID illness 12 weeks ago. This doesn't mean that they still have COVID 12 weeks later, or that they're infective or anything like that in any way. They've still got some symptoms 12 weeks later. I will be honest in saying that I'm not hugely involved in the long COVID side. I see patients that have had severe COVID 12 weeks or 8 to 12 weeks later, and that's really more as a checkup. And the majority, I mean, the good thing to report from an anecdotal response, but also some data coming out, is that those patients do make the majority of those patients do make a good and full recovery from a lung perspective in terms of damage. But yes, I do still see patients who more than 12 weeks after having contracted COVID still talk about symptoms of fatigue and lethargy and some shortness of breath. If anything, that would perhaps act more impetus for me to get vaccinated. But of course, as I've said, having the vaccination itself doesn't specifically mean that you won't get COVID. It means that it won't be severe. Well, not won't be, it's a significant reduced risk of getting severe or hospitalized with it. Yeah, but of course, if you still have symptoms 12 weeks later and they're having an impact on your life, then most certainly, please, as I said before, please do see your GP, because there are accepted pathways of referral to local long COVID clinics. There are some assessments that need to be done often, like chest x-rays and things, if they're, particularly if they're chest symptoms, and some other tests as well. There's there's a whole cohort of things that have to be done before the GP can make the referral to a long COVID clinic, but the support is out there. You know, I admit at the start it was a bit of a struggle when you're having to start any new service. Things are slow, and there wasn't support for a lot of people for quite a while. I freely admit that, but that is a situation that is improving, and there are long COVID clinics all over the country now. So if you do still have significant symptoms, you feel more than 12 weeks after having had your initial COVID illness, then that is something definitely to see your GP about, so that you can know whether you need to be assessed further or even referred to a long COVID clinic.
This is exactly what happened to a lot of our beneficiaries who thought they had COVID. They used to come back to us and ask us, because there was, as you said, services were implemented. It wasn't as good as now. So they used to come to us as a charity we had to support. So we were working with Public Health Wales, Public Health England, to ask them a lot of queries. There are so many online, but the problem is nobody goes online. They're there, information is there, but they really want to speak to someone personally, either GP or someone to talk to. That's the reason why we are here. And thank you very much for having spent an hour with us. We really appreciate your time. Any more questions, or we will wind up? I'll give you one more minute if there is anybody who would like to ask any questions. We're going to come back again sometime in the new year with any other topic related to COVID or cancer awareness. As I said, we'll come back again for the information session. And thank you very much, Milind and Rajiv, on behalf of the mentoring. Would like to thank you all.